Myofacial pain syndrome, or MPS, is a chronic regional pain condition that affects millions of people worldwide. It is characterized by trigger points, hyperirritable spots within taut bands of muscle fibers which cause both localized and referred pain. These trigger points can be either active, producing spontaneous pain, or latent, becoming painful only when stimulated. PS is often underrecognized due to symptom overlap with other pain disorders like fibromyalgia, neuropathic pain, and joint disorders. Factors contributing to its onset include muscle overuse, postural imbalance, systemic conditions, and psychological influences. The prevalence of MPS varies, but it is a major cause of musculoskeletal pain, especially among adults and those in occupations requiring repetitive movement. Understanding the basics of MPS is crucial for recognizing its impact and guiding proper diagnosis and treatment. PS is a multifactorial condition influenced by physical, systemic, psychological, and lifestyle-related factors. Muscle overuse, repetitive strain, and poor posture are well-documented physical risks, often seen in manual labor, sports, and prolonged desk work. Systemic factors like vitamin D deficiency, hypothyroidism, and iron deficiency can impair muscle function and recovery, increasing susceptibility to trigger points. Psychological stress, anxiety, and depression are also central contributors, as chronic tension leads to sustained muscle contraction and heightened pain sensitivity. Lifestyle behaviors, including sedentary habits and sleep disturbances, further exacerbate symptoms. The pathogenesis of MPS involves several hypotheses, such as the Cinderella hypothesis, neuromuscular junction dysfunction, and central sensitization, all describing how trigger points develop and persist. These mechanisms highlight the complex interplay between peripheral muscle changes and central nervous system responses. Diagnosing MPS is challenging due to the lack of standardized criteria and frequent symptom overlap with other chronic pain conditions. Clinicians typically rely on patient-reported pain, exclusion of other pathologies, and palpation of trigger points. Major diagnostic criteria include localized pain, referred pain patterns, taut palpable bands, tenderness at trigger points, and reduced range of movement. Other criteria involve pain reproduction upon pressure, local twitch response, and pain relief after stretching or injection. Recent advances in diagnostic tools such as quantitative sensory testing, algometry, ultrasound, and electromyography offer more objective measures but are not yet widely adopted. Differential diagnosis is essential, as MPS can mimic fibromyalgia, neuropathic pain, and joint disorders. Each condition has distinct features such as the presence of trigger points in MPS, widespread pain in fibromyalgia, and neurological signs in neuropathic pain. Accurate diagnosis guides effective treatment and improves patient outcomes. Effective management of MPS requires a patient-centered, multimodal approach that integrates both pharmacological and non-pharmacological therapies. Local anesthetic injections are well supported by evidence and provide consistent pain relief and functional improvement. Needling, acupuncture, magnetic stimulation, ultrasound therapy, laser therapy, extracorporeal shockwave therapy, and manual therapy show some effectiveness, especially compared to placebo, but their comparative benefits remain inconsistent. Muscle relaxants, antidepressants, gabapentin, opioids, topical lidocaine, capsaicin, and kinesio tapping have inconclusive or insufficient evidence for MPS. Non-steroidal anti-inflammatory drugs and diclofenac are generally not superior to other treatments. The best outcomes are achieved when treatments are tailored to individual patient needs, combining empirically supported methods with ongoing evaluation. High-quality research is needed to refine these strategies and improve long-term patient quality of life. Myofacial pain syndrome is a complex biopsychosocial condition that requires careful diagnosis and individualized treatment. Despite advances in understanding its mechanisms and risk factors, MPS remains challenging to diagnose and manage due to symptom overlap and lack of standardized criteria. The integration of evidence-based therapies, especially local anesthetic injections and selected physical modalities, offers hope for improved outcome. Patient-centered approach, focusing on shared goals and tailored interventions, is essential for effective management. Future research should prioritize refining diagnostic methods and evaluating the long-term effectiveness of integrated treatment strategies. By advancing clinical knowledge and practice, healthcare providers can better address the needs of patients with MPS, ultimately enhancing their quality of life and reducing the burden of chronic pain.